Hello and welcome to the Sexual and Reproductive Coercion webinar presented to you by Planned Parenthood Ottawa. My name is Ayan Ali. I am the Sexual and Reproductive Coercion Project Coordinator. And today we're going to be talking about reproductive coercion, um, how it's related to domestic and systemic violence, and what it may look like or mean to break down silos between Ottawa's gender-based violence and sexual and reproductive health sectors. So just a quick overview of everything that will be discussed. We go over what sexual and reproductive coercion are. Reproductive coercion, is it a form of domestic or systemic violence? The relationship between reproductive coercion and intimate partner violence, the effects of reproductive coercion across intersections and how it may manifest across intersections, barriers to sexual and reproductive health care experienced by marginalized individuals, silos between Ottawa's gender-based violence and sexual and reproductive health sectors. What is the Sexual and Reproductive Coercion Project? Go over a summary, or rather a summary of a needs assessment that was conducted by the former Sexual and Reproductive Coercion Project Coordinator, Samuel Lugoma, in a collaboration with Stephanie Lamotsky. The objectives of the Sexual and Reproductive Coercion Project, how the Sexual and Reproductive Coercion Project can serve the Ottawa community, and Emily, I'm going to let you know about a lunch and learn event that Planned Parenthood Ottawa will be hosting for the project in January. So we're going to talk about that in a bit. So what are sexual and reproductive coercion and how are they related? So sexual coercion specifically is a form of sexual violence that occurs when an individual is tricked, pressured, forced, threatened into having sex in a, quote, non-physical manner. So they are not, it is a form of sexual violence, but the person isn't necessarily physically forced. It's usually done by wearing down an individual with constant requests for sex, tricking someone into having sex. An individual may be threatened. The abuser might threaten to end a relationship, spread gossip, create other social consequences if someone refuses to have sex with them. And finally, and this is very common, having an authority figure use their influence to pressure one into having sex. Reproductive coercion, on the other hand, it's any behavior that limits an individual's ability to decide when and under which conditions they choose to parent or not parent. It's limiting someone's reproductive choices to not parent, their options for preventing or ending a pregnancy, and this is achieved through the use of manipulation, intimidation, threats, and or actual acts of violence. So reproductive coercion. Domestic or systemic violence? It's both. Reproductive coercive behaviors can generally, at least in the context of a domestic situation, can typically be grouped into three types of behaviors. So we have birth control sabotage, pregnancy pressure, and pregnancy coercion. Birth control sabotage is hiding or destroying birth control pills. It's removing contraceptive patches. It's something called condom manipulation. Condom manipulation includes things like what young people generally refer to as stealthing. Stealthing is when an individual removes a condom during sex or before sex without the knowledge or consent of the person that they are having sex with. This is really common. This is generally common, but this is especially commonly experienced by young women, typically between the ages of 16 to 25. pregnancy pressure includes things like threatening to leave or be unfaithful to a partner in order to pressure them to become pregnant when they do not wish to do so. Um, yeah, so it involves more emotional and verbal abuse, emotional abuse, um, to pressure someone into becoming pregnant against their will. But then we have pregnancy coercion, which involves actual threats or acts of violence if an individual fails to comply with a decision concerning either the continuation or termination of a pregnancy. And this can escalate to um, an abuser injuring a partner with the intent to cause a miscarriage. So before getting into how prevalent domestic reproductive coercion is, um, I want to note that reproductive coercion is highly underreported in Canada. This is because it's often not understood as its own unique form of abuse. But as of now, there is quantitative data illustrating the prevalence in Canada specifically. So we're going to rely over the course of this presentation on recent up-to-date US findings. These US findings are drawn from large, diverse sample sizes from metropolitan areas, so we can assume that they are generalizable. So in the United States, most studies have found that the reported prevalence of reproductive coercion is somewhere between 15 to 25% of the female population. The percentage is higher among more marginalized women, and that is quite a large margin. And I want to note that even though this data typically illustrates a male partner's dominance over a woman, a cis man's dominance over a cis woman in a heterosexual union, it may also occur as a cis woman's pregnancy coercion over a cis man. It can happen in relationship involving trans individuals, within same-sex relationships, gay relationships, or intergenerational relationships, and intergenerational relationships having reproductive coercion in those contexts often involves limiting the reproductive choices of individuals with disabilities. It can happen in some cultures with in-laws being coercive towards, um, you know, the spouse of their child, et cetera, et cetera. So systemic forms of reproductive coercion. Outside of the scope of intimate partner violence, reproductive coercion is often perpetrated systemically, usually by sexual and reproductive health service providers and medical professionals. So an example of this is women with disabilities experiencing discriminatory beliefs and abuse related to their reproductive related to their reproductive choices. Rather, they are assumed to be unable to make informed, appropriate decisions related to their reproductive choices, their reproductive health, and they're also assumed to not be sexual beings in general. Another example of a systemic form of reproductive coercion is the non-consensual sterilization of First Nations, Métis, and Inuit women. This has happened historically, but also we have recent reports that show that this is still an ongoing problem and it's still a form of state violence enacted on Indigenous women. So what is the relationship between reproductive coercion and intimate partner violence? So again, existing academic and community research demonstrate and confirm a relationship between intimate partner and reproductive coercion. There isn't enough demographic information in Canada, so we will continue to draw from various up-to-date US findings. Everything that I reference in the course of this presentation is within the last 5 years. So There is a positive association between experiences of reproductive coercion and experiences of partner physical violence. There's also an association between, a positive association rather, between reproductive coercion and reduced rates of contraceptive use due to condom manipulation or interference. Intimate partner violence and reproductive coercion are associated with a variety of negative health consequences. And infants of women who carried mistimed or unwanted pregnancies to term are more likely to suffer from health complications. So across intersections, the general impacts of reproductive coercion are feelings of powerlessness, increased acceptance of harm, so learned helplessness, symptoms or markers of depression or anxiety, and overall fear and impact on self-esteem. But now we can look at the effects of reproductive coercion across intersections. And we'll find that when compared to heterosexual women, bisexual, pansexual, queer women who do date or have sex with men are at an increased risk for reproductive coercion and intimate partner violence. They're likelier to experience lifetime intimate partner violence, more likely to engage in riskier sexual behaviors, report higher incidences of sexually transmitted infections, and they face greater barriers in accessing and receiving healthcare due to stigma and homophobic medical practitioners. Black women as well are an increased risk for HIV due to higher risk of victimization, high-risk sexual behaviors, and infrequent condom use. Young women who have contracted a sexually transmitted infection have a higher likelihood of experiencing or having experienced dating violence and reproductive coercion. Again, typically through condom manipulation or what I referred to earlier, specifically as stealthing. Women with disabilities are up to 10 times more likely to be sexually abused, and often their reproductive freedoms are restricted. That might be because their decisions are made for them by a caretaker, a caregiver rather, or they are not trusted to make what medical practitioners might describe as radical reproductive choices. Trans individuals in relationships with cis partners often experience coercion to use their reproductive capacities in cis-centric behavior. So what I mean by this is that there are a high number of reports of trans women, for instance, in relationships with cis women who might be expected to use their reproductive organs for the purpose of reproduction, for procreation. Or there are instances where trans men, for instance, are in a relationship with a cis person, whether it be a man or a woman, and are expected to carry a fetus to term. And there might be little regard for how this person may feel about their body, serving these roles. They might experience dysphoria as a result, and all of these fall under reproductive coercion and abuse more generally. There's also pressure on individuals who've contracted HIV or who are HIV positive to not reproduce. So again, a high incidence of women with HIV who are encouraged to have hysterectomies by medical practitioners. Newcomer or immigrant women are vulnerable due to language barriers, systemic discrimination, racism, isolation, and threats to their citizenship status. So this may come from the individual who is their sponsor. This may come from the practitioners or the service providers that they come into contact with. So barriers to sexual and reproductive health care. Women who experience intimate partner violence and reproductive coercion are more likely to experience unintended pregnancy, abortion, whether that's elected or forced, and STIs and or HIV. Women who will report reproductive coercion are also more likely to delay accessing needed contraceptives and are less likely to use a prescription method. This, again, because reproductive coercion in a domestic situation is often related to intimate partner violence or domestic violence in general. So this person might lack access to contraceptives and other prescription methods due to the nature of their abuse and the habits of their abuser. Reproductive coercion is also a pathway for increased HIV risk among women. So, looking at the silos between Ottawa's gender-based violence and sexual and reproductive health sector, there is a significant gap in available research and best practices in a holistic, cross-sectoral approach, which results in what we could refer to as knowledge creation silos between community support workers, advocates, activists, and health researchers. Reproductive coercion is both a public health concern and a form of domestic and interpersonal and systemic violence. In Ottawa specifically, referral inefficiency, medical prioritization by sexual and reproductive health spaces that fail to put in trauma-informed practices, anti-gender-based violence organizations having access to but not necessarily sharing their varied experiential knowledge basis and resources, and the complicated, nuanced ways individuals experience reproductive coercion, all of that creates, it's like a perfect storm. So it creates a situation where neither sector nor any one organization is adequately situated to address reproductive coercion. So ask yourselves, how do you, in your work, navigate the silos between these sectors? And again, this ties into the purpose of this project, and we'll get back to that in a moment. Sexual and reproductive coercion needs assessment conducted in 2018 in the following summary. So the former sexual and reproductive coercion project coordinator, Samuel Lugoma, with Stephanie Lomotsky, gathered data from service providers from local, provincial, and national sexual reproductive health and gender-based violence organizations. They focused on supporting the lived experiences of marginalized individuals. So they focused on service providers who support marginalized individuals, and by marginalized individuals here, I mean LGBTQ persons, young mothers, individuals with disabilities, women of color, First Nations, Métis, Inuit women, and those living with HIV. So everything that was gathered in that study has informed this presentation thus far. So what is the Sexual and Reproductive Coercion Project? It's a project that seeks to build a coordinated community response to reproductive coercion and abuse by increasing communication and knowledge sharing between anti-gender-based violence workers and sexual and reproductive health workers. By this, I mean that by increasing knowledge sharing, communication, by working on the relationships that service providers have in both sectors, then both sectors can do a better job of supporting service users in Ottawa and making sure people don't fall through the cracks. So the objectives of the Sexual Reproductive Coercion Project are as follows. Create an advisory council. The purpose of the advisory council would be to establish trauma-informed best practices, just a protocol for sexual and reproductive coercion screening, meaning that if an individual is accessing an organization or a service by an organization that focuses on anti-gender-based violence or focuses on sexual and reproductive health, that these individuals are being screened for reproductive coercion in a trauma-informed, culturally appropriate ways, in a way, and that service providers are aware of reproductive coercion and how that will create barriers to the services that the person is attempting to access, or how it might inform the choices that they make, and providing support for that. Thirdly, resource development for service providers. And fourth, a referral pathways feature. And by this, I mean that in Ottawa, any service provider who attempts to to give referrals is limited by the fact that there's no document or feature or program in Ottawa that allows service providers to go through and find the most appropriate referral that they can make to a service user. So how the Sexual and Reproductive Coercion Project can serve the Ottawa community. So anti-gender-based violence or anti-violence against women workers, particularly frontline workers, are often the first to assess and identify intimate partner violence and systemic barriers to receiving support and care for any individual user, service user rather. There's an identified need for health providers to assess for reproductive coercion and tailor contraceptive counseling to clients who may be experiencing domestic violence and reproductive coercion. Screening and assessment by health professionals are key for detecting and preventing intimate partner violence and reproductive coercion. And finally, patients report that sexual and reproductive health providers trained in intimate partner violence and reproductive coercion are likelier to have discussions with them surrounding healthy relationships and provide more resources on intimate partner violence and make better referrals to organizations that can support their service user. Sexual and reproductive health providers would benefit from being trained on gender-based violence red flags, screening tools, safety planning, identifying and challenging implicit bias that can lead to systemic forms of reproductive coercion. They can benefit from being trained on harm reduction, such as undetectable birth control, and this would create a stronger relationship between the gender-based violence and sexual and reproductive health sectors, and making sure that this relationship is stronger and creating knowledge sharing and better communication would facilitate that between sectors. So we need to develop culturally appropriate healthcare screening and best practices to address individuals with marginalized identities and make sure that they aren't falling through the cracks when they're attempting to access services across both sectors. And finally, the Sexual and Reproductive Coercion Project is having a lunch and learn event in January of 2019. And so this is going to be an opportunity to provide feedback, to ask questions about the project, about the objectives, about the activities that will lead to these objectives, hopefully. If you are interested in collaborating, please come or shoot me an email. My name is Ayan Ali, and my information will be found on the site, on the Planned Parenthood Ottawa site. So thank you for your time, and hope to see you soon. Please stay tuned for our Facebook and Twitter announcements for when this event will be.